Hello, my name is Amir. I'm pleased to say that I'm a dental surgeon and I'm here to talk to you, a budding dentist, a general dental practitioner perhaps, a dental therapist, or anyone for that matter, about heart failure. But before I talk to you about heart failure, I'm going to talk to you a little bit about the anatomy and the physiology of the heart. And I'm going to start by telling you that the heart is a pump. Well, it's actually two pumps, isn't it? We have the small pump on the right that is collecting all the dirty blood, the deoxygenated blood, and pumping that deoxygenated blood through the pulmonary circulation to the lungs for oxygenation. And all that clean blood is then, oxygenated blood is returned to the big pump on the left, which then pumps it to the rest of the body. Two hearts working together, side by side, hand in hand, day after day and night after night for the rest of your life. The heart has four important chambers. The collecting chambers which sit on top of the heart, the left and right auricles, and the pumping chambers, the engines, the left and right ventricles. If you were to take a chest x-ray and look at the heart from the front, you will notice that the major piece at the front of the heart is formed by the right ventricle. The right ventricle that is pumping deoxygenated blood through the pulmonary circulation to the lungs for oxygenation. The right border of the heart is formed by the right collecting chamber, the right auricle. The left border of the heart is formed mainly by the main pumping chamber, the left ventricle. The left auricle is not visible from the front. It lies at the back of the heart. The exit from the right ventricle is obviously the pulmonary arteries to the lungs for oxygenation. And the exit from the left ventricle is the aorta, supplying systemic circulation with oxygenated blood. The heart has its own blood supply. The coronary arteries, the left and right coronary arteries, and if you were to look at the same chest x-ray, you will notice the major branches of the left coronary artery going up at the front. Those are the anterior descending branches, and the ones at the back are the circumflex branches. Now it's important to bear in mind right at the beginning that the right ventricle is working against the low pressure. The pressures in the pulmonary circulation is low, 20 millimeters of mercury. Therefore, it's not very thick. 3 millimeters or so thickness. It's only pumping to the lungs and back. The left ventricle is pumping blood against the systemic blood pressure. The pressures there are 5 times greater, 100 millimeters of mercury mean. It's not surprisingly 3 to 4 times thicker, a centimeter or so in thickness. And you know something about the structure of the heart muscle, I'm sure. If we took a section through the left ventricle, we have the pericardium on the outside, which is just a double layer sac covering the heart. In the middle, we have the myocardium, specialized cardiac muscle cells, the engine. And on the inside, we have the endocardium, smooth, glistening layer covering all the cavities of the heart and reflecting herself over the valves. So when we talk about valvular disease of the heart, we're talking about the disease of the endocardium. Now the last thing I want to talk to you before we go on to heart failure is talk to you a little bit about the engine, the myocardium, specialized cardiac muscle cells. Well, I mean, this is skeletal muscle cells in the bicep. Then how come this engine, this muscle, cannot work more than an hour before it fatigues, before it's overcome and is drowned herself in lactic acid? How come this engine, which is no bigger than your fist, can pump 5 liters of blood every minute, 300 liters an hour, 7,000 liters a day, 250,000 liters a month? How does it do that without fatigue? But the answer lies not so much in its chemistry, because the cardiac engine is striated. That means it has the same proportion of actin and myosin in its chemistry. And yes, it is infiltrated with billions more of mitochondria, hence ATP and energy. But that doesn't make the cardiac engine efficient and special and specialized. The answer is the size of the cardiac engine and the way they're connected together. The skeletal muscle cells in the bicep are centimeters in length, 100 microns in width, multinucleated and featureless compared to the cardiac engine. The cardiac cells are individual cells, single nucleated, 20 microns by 100, 20 microns by 100. And these individual cells are connected to the neighbour by a special gap junction, an interclated disc. And that means now there is a rapid transfer of ions possible between cells. Cells can communicate together. So potassium and sodium and chloride ion can go from one cell to the next unimpeded, without there being a gate. But more important than that, these interclated discs connect the cardiac cells, not as if they were building a wall with it, but as if they were building a pyramid with it. The cardiac cells do not just connect together in any random way, they individuate with one another in a step formation to give the heart the rigidity, the strength, the colossal power that it requires. Because that is, after all, what we want, isn't it? We want a strong heart, don't we? We want a heart that is going to generate enough pressure during systole to pump that blood from the left ventricle into the aorta. And these interclated discs allow for that. But more important than that, they allow electricity through action potential. So if you were to get a pacemaker and place that pacemaker on the right auricle, on the right collecting chamber, and if that pacemaker were to fire an electrical impulse like it does every second or so, that electrical impulse will sweep through the entire myocardium. And you hear the lub, and before you've heard the dub, the heart is contracted as if it were just one cell, one unit, a functional syncytium. And that's precisely what it is, isn't it? A functional syncytium. So now that we've covered the necessary anatomy and physiology of the heart, let's talk about heart failure. So what is heart failure? Well, the heart is a pump, and all pumps fail. If they are mechanical pumps, they fail. If they are electrical ones like the heart, they fail. And it's very difficult to put a definitive or a precise definition of exactly what heart failure is. But I think we can safely say, for our purposes, it's a condition in which the heart, the myocardium, the engine fails to maintain an adequate circulation, an adequate blood supply to the body's organs. And if these organs are vital organs, such as the brain or the kidneys, then obviously there are serious results, serious consequences. Now, doctors artificially divide heart failure, and they tend to talk about left heart failure, and they tend to talk about right heart failure. And when the two hearts fail together, as they often do, that's what happens in most cases. Both hearts fail together. They then call it congestive heart failure. So let's talk about each one in turn. When the left ventricle fails, they call that left ventricular failure, left heart failure. And that's reasonable, isn't it? And when the left ventricle fails to empty, all that blood is going to get jammed up in the left auricle. And behind that, in the pulmonary veins, and behind that, in the lungs themselves. The pressure in the pulmonary capillaries is going to rise, and edema and fluid is going to exude into the alveoli. Our patients' lungs are going to become waterlogged. They cannot oxygenate their blood, therefore, and they become desperately short of breath, gasping for air. A posh word for shortness of breath is dyspnea. And so the major feature of patients with left ventricular failure is dyspnea. due to pulmonary edema. Right heart failure can occur on its own, rarely, comparatively rare to the left side. And then we have to think of things that would do that on the right side. And the common things are like chronic lung disease, where the right ventricle has to work harder and harder and harder to pump that blood against the diseased pulmonary circulation. And it's not surprisingly that in time it will fail. Or you've seen patients walking around town or on the wards with the disease of the thoracic chest wall, the bending of the spine, kyphoscoliosis. Their right ventricle has to work harder because it has to pump blood against an abnormal pulmonary circulation. And it will fail. And the third main cause of right ventricular failure is an illness called the pulmonary emboli, an infarct. That is, patients are put in bed. I need not bother telling you why patients are put in bed. I mean, if someone is desperately short of breath, there isn't much else you can do except put them to bed. And if someone is in bed and they have a poor cardiac output, little bits of clot will form in veins in the leg or in the pelvis, will fly through the circulation, go through the heart and land in the lungs and produce an illness called the pulmonary emboli, an infarct. And when the right ventricle fails to empty, all that blood is going to get jammed up in the right auricle. And behind that, we're going to have congestion. We're going to have systemic venous congestion. And we're going to have congestion of the organs that drain on the right side, like the liver. And we're going to have edema. But that edema is not going to be in the lungs, but in the dependent parts and body cavities. So if you're walking around, that means around your ankles. If you're lying in bed, that means around your lumbosacral region. So you wouldn't expect patients who are in bed to show much ankle edema because they're likely to have it in their dependent parts. And the most dependent part in bed is the lumbosacral region. And so the major feature of patients with right ventricular failure is systemic venous congestion and peripheral edema. And now that we come and talk about congestive heart failure, and as I said to you, this is what happens, as in most cases, both hearts fail together. We put the major features of left and right ventricular failure together and say patients have systemic venous congestion and peripheral edema, and they have dyspnea due to pulmonary edema. And congestive cardiac failure is an extremely common medical condition. Many hundreds and thousands of patients in the United Kingdom alone will develop it to one degree or other. Many elderly patients will develop heart failure. So now let's talk about the causes of heart failure. In other words, what makes the heart fail then? Well, the heart is a pump, and if the pump wears out, that would be an important cause of congestive cardiac failure. And the most important cause, the most common cause, is the disease of the heart muscle, the engine cause. And the most important cause of muscle disease is the disease of the coronary arteries. The coronary arteries become occluded with plaque and atherosclerosis. The muscle becomes fibrotic, and in time it fails. So muscle disease of any kind would be an important cause of congestive cardiac failure. The second cause of left ventricular failure is some sort of valve disease. Either the valves become narrow or stenotic, or they become incompetent. Either way, the left ventricle has to work harder and harder, and in time it will fail. And the third main cause of left ventricular failure is systemic hypertension. The blood pressure is unduly raised, and the left ventricle has to work harder and harder to pump that blood against an increased peripheral resistance, and it will fail. So within these three, we have the major causes of left heart failure. Muscle disease, valve disease, and systemic hypertension. And I've already told you that right heart failure can occur on its own, but comparatively rare, and those things are like chronic lung disease, where the right ventricle has to work harder and harder to pump that blood against the diseased pulmonary circulation, and it will fail. Or disease of the thoracic chest wall, kyphoscoliosis, the bending of the spine, where the right ventricle has to work harder to pump blood against an abnormal pulmonary circulation, and it will fail. And the third main cause of right ventricular failure is a pulmonary emboli, an infarct. So within these 6 causes, we have the major causes of heart failure. Muscle disease, valve disease, systemic hypertension on the left, chronic lung disease, disease of the thoracic chest wall, and a pulmonary emboli on the right. Now, other than these 6 causes, doctors recognize some important accessory risk factor. And the most important accessory risk factor is age. I mean, your heart can't go on pumping forever. It may pump till you're 86 and fail because the myocardium is ancient. I mean, there may be a degree of underlying coronary artery disease, but age is a very important accessory risk factor. Anemia is another important accessory risk factor. That is, if the myocardium is not getting enough oxygen herself and has to work harder to pump oxygenated blood to the various tissues, it may tip it into heart failure, particularly so if you have any of the other causes. So age is an important accessory risk factor. Anemia is an important accessory risk factor. And if you have an overactive thyroid driving your heart at a faster rate, that too would become an accessory risk factor. So thyrotoxicosis of any cause would be an important accessory risk factor. Now, before I leave you the causes, I should perhaps mention to you a condition called cardiomyopathy. Cardiomyopathy is another name for muscle disease. I have already told you that coronary artery disease causes muscle disease, but there are a large number of other conditions which tend to do the same. In some cases, the myocardium is inflamed because of a viral infection. In some cases, the myocardium is infiltrated with abnormal material. In some cases, we know certain drugs poison the cardiac muscle. These are all lumped together and called cardiomyopathy. So if someone who is young with a normal blood pressure, no valve disease, no chronic lung disease, and no underlying coronary artery disease goes into cardiac failure, it would make the likelihood of a cardiomyopathy extremely likely. So we've talked about the causes. Let's talk a little bit about the symptoms of heart failure. A posh word for shortness of breath is dyspnea, difficulty with breathing. So we talk about dyspnea as being the principal or the major symptom of patients with heart failure. And from what I've said to you already, you probably realize that it is most common when the left heart fails. May I go over this again? The left ventricle fails to empty, the left auricle becomes congested, the pulmonary veins become congested, the pulmonary capillaries become congested, the pressure within them rises, and edema and fluid will exude into the alveoli. Our patients' lungs are going to become waterlogged. They cannot oxygenate their blood, therefore, and become desperately dyspneic, desperately short of breath. Another feature is edema. Tissue fluid around the cells in the various tissues, and that is most likely to occur in the dependent parts. So if you're walking around, that means around your ankles. If you're lying in bed, that means around your lumbosacral region. So you wouldn't expect patients who are lying in bed to show much ankle edema because they're likely to have it in the dependent parts, and the most dependent part in bed is the lumbosacral region. Fluid can also occur in the body cavities so that the chest can fill up. A pleural effusion, fluid in the pleural cavities outside the lung next to the chest, that can occur in patients with heart failure. The abdomen can swell because of the retained fluid, that is called ascites, ascites, and also the liver can become congested. I'll come back to that in a minute. So that patients complain of shortness of breath, swelling of the ankles, and by the time they're seen at the consultant, there may be fluid in the body cavities. Also, very rarely you get fluid in the pericardial cavities, but very rarely. Another symptom of patients with heart failure is that they complain of right abdominal pain. That is because the liver is congested, is tense, is stretched as capsule, and instead of being tucked underneath the costal margin, is way up here. Why is the liver congested? Because the right ventricle fails to empty, the right auricle becomes congested, and we're going to have congestion of the organs like the liver, which drain on the right side. And that is why they have congestion of the liver and painful liver. So now let's talk a little bit about this shortness of breath. It's called effort dyspnea because it comes about when patients do things. Doctors call it effort dyspnea, and they grade it from 1 to 4. So they talk about effort dyspnea, grade 1, grade 2, and grade 3, and they give patients various tasks. Can you walk 5 yards or so? Can you go up and down the stairs? Can you do so and so and so and so and so and so? So the next time they can see you, they'll know whether you're more dyspneic or whether you've made progress. Another thing which happens with patients that have left ventricular failure, congestive heart failure, is that they complain of shortness of breath, not when they're walking, not when they're going up and down the stairs, but at night. So it wakes them out of their slumber. Then that is called paroxysmal nocturnal dyspnea. It's called paroxysmal because it occurs in attacks, nocturnal because it happens at night time, and dyspnea because that's what it is, shortness of breath. I mean, patients will not come up and say to you, last night I had paroxysmal nocturnal dyspnea. But they will come up and say, my wife made me a lovely meal last night and I was doing perfectly well for myself. I went up down the stairs, I took my clothes off. I was perhaps just a little bit short of breath taking my clothes off. And I went to bed, I read my book and I fell asleep. And I woke up at 3 a.m. desperately short of breath, gasping for air. I had to sit up. It was very unpleasant, very uncomfortable. And sometimes that is called cardiac asthma or paroxysmal nocturnal dyspnea. And there are various reasons for this. I need not bother telling you all about this. I'll suffice it to say that if you lie someone flat in bed, you compromise the failing heart further. And that's what normally people do when they go to bed. They lie flat in bed. And when you lie someone flat in bed, you increase the inflow of blood to the right side and you decrease the pulmonary venous drainage on the left, and the lungs become squeezed in the middle, and you end up with cardiac asthma or paroxysmal nocturnal dyspnea. Perhaps I should talk to you a little bit about the causes of the edema, because you are correctly saying to yourself that there is a rise in the venous pressure that is transmitted to the capillaries, and edema and fluid is going to exude between the cells like Starling said it would, Starling's law. But it's not quite simple as that. And the main reason why patients with heart failure develop edema is because there is renal abnormality. The circulation to the kidneys is impaired, and the kidneys scream and shout and make an order, for goodness sake, we are suffering here, retain fluid. And they secrete aldosterone by the bucketful. Aldosterone, which is a potent sodium and hence a water retaining hormone. They overdo the job. They overcompensate. And you end up with edema on top of what Starling said it would. Starling's law. Patients may not necessarily notice the edema, but they will notice the end results. So if you were to ask them, Mrs. Smith, are you passing less urine? The answer will come back as, yes, I'm passing less water. They are passing less water because they are retaining it in the various tissues. So they have polyuria. And another thing which happens with patients with heart failure, an interesting thing that happens is that there is a reversal of the normal rhythm, which makes you pass more water at daytime than at nighttime. In patients with heart failure, the opposite occurs. So they have nocturia. So we've talked about the causes, we've talked about the symptoms. Let's talk about the physical signs of what you would see in patients with heart failure. Because with medical patients, you're not meant to touch them, you're meant to look at them and say what you would see. So what would you see? Well, you certainly would see someone who is desperately short of breath, desperately distinct for the reasons that we have discussed. The lungs are congested, they're full of fluid, they cannot oxygenate their blood and therefore become desperately short of breath. So you will see someone who is short of breath. What else would you see? If you look at the mucous membranes, they may be blue. So you may be dealing with central cyanosis. Well, actually, in order to do that, you have to look at the organs inside the mouth, because as you know, the hands and the lips are subject to the outside cold, as they may be this morning, so there may be some cyanosis due to sluggish circulation. So if you're gazing in somebody's mouth, and you see the tongue which is blue, you may be dealing with someone with heart failure. Mind you, lie them so flat these days that they wouldn't be able to manage it. What else would you see? Well, if you look in the neck, you will see the most important physical sign of patients with congestive heart failure. There is jugular venous congestion. The external jugular vein is congested on both sides, and if you can't see it, you will certainly see its upper border pulsating, a double or a triple pulsation. And that is the most important physical sign of patients with heart failure.